Good morning, everybody, and thank you so much for joining us in this somewhat unusual approach, but only because we thought that it would be reasonable, given what we've done in these 31 webinars up to date, which is we've presented information to you on a wide-ranging collection of topics that cover a lot of different aspects of the most common chronic diseases, consistent with the focus of the Closing the Gap grant initiative. And we know that sometimes we don't always have sufficient time to engage questions that you have, or even questions that you've submitted through the chat. And it's important for us to make sure that we try to give you as deep a dive as we can on issues that you are concerned about, to make sure that we're connecting the dots, that we are making this matter for you, that we're making this relevant for you. So what you have here is a summary overview of many of our webinar learning objectives. I don't have all of them because we've covered a lot of material, and as you know, there've been a lot of repeats, but that's intentional, because much of what we do relates to the interconnectedness of chronic diseases. You've heard us say over and over again that where you see one, you're likely to see another. You see kidney disease, you're going to see heart disease. You see diabetes, you're going to see some of these other cardiovascular disease, and right on down the line. So we've had many discussions on heart disease and diabetes. We've talked about prevalence and risk factors. Risk factors has been a common theme. That is, those things that make you susceptible to developing a chronic disease. And remember that certain conditions are also risk factors. You know, high blood pressure is a condition, but only when it's above a certain level, it becomes a risk factor for other problems like strokes and atherosclerosis and kidney disease. You've heard a lot about signs and symptoms of acute cardiovascular events. There's been a lot of attempts to make sure that you recognize when somebody's having a heart attack or a stroke, what to do about it in the moment. We've spent many, many minutes talking about nutrition, the role of healthy nutrition in various chronic diseases. Dr. Morrison has made elegant presentations. She's also presented at our self-management courses in person, at the face-to-face sessions that we've had. We've tried to equip you with some insight into what makes for healthy nutrition, what keeps you out of the hospital, what keeps you safe during periods like holidays and special celebrations. And so a lot of resources have been presented to you on healthy eating. And we have not ignored the fact, and we are sorry that Dr. Gervais had an emergency situation, but we are sorry that she won't be here. But we've spent time, and you've heard from Dr. Deborah Dallam on the impact of mental status on diseases, chronic diseases, how your mind affects the status and the progression of different diseases, how stress affects chronic diseases, including things like cancer. And then, of course, risk factors. What is your risk for all of these different diseases, starting with cardiovascular disease, diabetes? What are those risk factors? Which ones of them can be changed? Which ones of them can't be changed? And that's a very, very important dynamic. Early detection. Remember, we've talked about early detection is the enemy of better outcomes. Okay, I mean, late detection is the enemy of better outcomes. Early detection is the best strategy that we have to prevent poor outcomes. Cancer, we talked about a lot. We did a deep dive on cancer, why it's so prevalent in communities of color like ours. What are the different types of cancer? Solid organ cancers like pancreas, breast, colon, prostate, gender-specific cancers like cervical cancer in women, prostate cancer in men, blood cancers. That is, the blood, we talked about this, is the only liquid organ that we have, and yet there are cancers of that organ system like leukemias. So we talked about
Dr.
protection.
Gavin, I'm so sorry. I know this is out of the norm. Will you put this on your radar in the Q&A piece? I was listening to CNN just this morning, and they were talking about all of the advancements in cancer, but the fact that not enough clinical participants in the clinical trial,
Yeah.
5% of people. I would love to hear your response and some of the other
I,
medical doctors on that. Thank you, sir.
I will be happy to address that because Dr. Reynolds and I had this discussion, Pastor Philpott, just the other day about how we can use the mechanisms that CHP uses, like health fairs, to make sure that our communities are more aware of what clinical trials are, what they do, what advantages they have for communities, what it means to be a participant in clinical trials, because that's the only way we get answers to many of these questions. The only way the FDA is going to approve something to be used for our benefit is that it will go through the appropriate structured clinical trial. So it's a very, very important point. And then finally, we talked over and over about hypertension, heart failure. Remember, we talked to you about the fact that heart failure is more common than heart attacks in diabetes. It's not something that we think about a whole lot, but it occurs more commonly, and it is a much more debilitating issue. We were so delighted when we had an opportunity with Melissa Groths, who talked to us about oral health and its relationship to chronic disease, because this is one of those areas that is under addressed in the realm of chronic disease. And she talked about the degree to which inflammation is such an important factor in chronic disease causation, how bacteria in the oral cavity serves as a stimulus for a variety of chronic diseases, and what the strategies are and the recommendations are for preserving good health. And then finally, we don't have Dr. Ty on, but you will remember that we had a very comprehensive session on women's health issues. Okay, and just because there were women's health issues did not mean that men were not going to be participants. There were a lot of men on, and it's important that we understand what these issues are, because we're talking about a variety of of cancers and other conditions that are triggered by inflammatory states, fibroids, endometriosis, various kinds of cancer, even polycystic ovary disease, uh, as both an inflammatory disorder and an endocrine disorder that really requires a team approach. So these are the kinds of things that we tried to cover. There are lots of questions that derive from these topics. I haven't included everything here, but this is just to jog your memory about the kinds of things we touched on in many instances multiple times, so that if you have questions related to this, or not related to this, but important to you, this is the moment. We don't claim to cover every level of expertise, but we do have a panel that has considerable depth here today. So we're going to now open it up to you and spend the rest of our time, as we should, talking about your questions.
Okay, I have a question that was sent over uh, as a registered person asked, other than surgery, how do you deal with knee and back pain? I repeat that. Other than surgery, the questioner is, how do you deal with knee and back pain? There's so many different ways to deal with knee and back pain. I suffer from both knee pain and back pain to a certain extent. But there is a device out there now. It's called StemWave. STEM. Hopefully somebody can put that in the chat. StemWave. STEMWAVE. And it is pretty awesome. It actually causes the migration, what we call mesenchymal cells, that is stem cells, into that area that is stimulating a little shock wave that goes to the area. And it actually causes what we call angiogenesis, which means that it creates its own blood vessel supply, but it also does something else very important. You know, mesenchymal cells, stem cells, are cells that are poorly differentiated. They can turn into cartilage, they can turn into bone, they can turn into muscle. This is where we're at today. And I have several patients now that I've been treating with it, of course, myself too. And here's a guy that's been walking with a cane, a quad cane, for several years. Walked to our office with his lovely wife, and I looked at him, and he was on the heavy side for sure. And I said, I don't know if it's gonna work for him, but you know what? I said, hey, why not try it? I got a video clip that I'll be sharing on our website of him walking, not only without a cane, but walking. They gone on a cruise. He was walking down, the cruise ships are long, are really long. He walked down the entire pier without a cane, walked back without a cane, and felt good after that. I saw him for his 9th or 10th treatment, I believe it was, a couple of days ago. This guy is awesome. So whenever you guys can avoid the knife, avoid it at all costs. Now, he did have a right total knee replacement, treat that area also. It increases his mobility big time. So his range of motion increased big time, and his pain is down to what we call minimal now. And he first came in, his pain scale was a 9 out of 10. Now he's a 1 to 2 out of 10. So that's STEMWAVE, STEMWAVE, and hopefully somebody will put it in the chat.
Dr. I have a question there. Now,
Sure.
you framed that to prevent surgery as the person who asked the question. What about if I've had surgery? What's the take on that?
A very good question. It's almost like this is a setup, but I like the question, Dr. Philpott. We had a young athlete, starting quarterback for an SEC team, I'll leave it at that, who came to our office because heard that we actually had STEMWAVE. He was scheduled to have surgery of his, he had a complex tear of medial meniscus involving his right knee. Father brought him in to see me. I talked with his athletic trainer. I talked with the team physician as well. Told him what we're going to be doing prior to his surgery. What was funny to me was that the surgeon said to me at this SEC major school, Dr. Owens, guess what? He says, we'll be getting our STEMWAVE in 2 weeks. He said, thanks for getting him started early. Because what it does is that it prepares even in the pre-op, as well as 2 to 3 weeks after surgery, you do the STEMWAVE also, and increases the healing process. Because it, like I said before, it increases what we call angiogenesis, that is increasing the blood supply to the area. And, got to keep it real, Pastor Philpott. We play golf. You have had STEMWAVE. I've had STEMWAVE. I give STEMWAVE all the time now. And my flexibility, my mobility, being even a diamond jubilee, amen. I hit that ball deep. Deep means long, by the way, guys. That's what that means. So I'll leave that alone. But thanks for the question. There's a question that someone has. I want to know if I have one of my good doctors on, Dr. Wilson Duvernay, ENT. Dr. Duvernay, are you on?
Yes.
Oh, great.
I am on.
Oh, good. Oh, this is lovely.
Dr. Reynolds, yes, hi.
Yeah, hi. Can I see your face, Wilson? I don't see your face, so I can come up from your.
Let's see if we figure out.
And I want to explain. I want to explain to you who Dr. Duvernay is. Super guy. Are you on, Wilson?
I am on.
Okay, I see. I see it. Okay, got it.
You see me?
Now, yeah, I see it. Good, great. Appreciate you, man. Dr. Duvernay is probably the finest, and I'm just exaggerating because I know him happen to be a person of color. One of the finest otolaryngologists that I've ever met, and I trained at Cleveland Clinic. Dr. Duvernay is a super ENT specialist. When I was having my voice problem, I went in to see him first. Because my voice had been like acting weird for like the last 5-6 years. So I hope I don't have no throat cancer and stuff. So I went and see Wilson. And he said, no, nigga, I said, code it up. And so I've been going back and forth to Cleveland Clinic to him. I check out, I trust, but I verify people, you know what I mean? But the bottom line is that Dr. Duvernay is somebody's special ENT. He has great bedside manner, which to me, I think doctors in general, like Tony, like Dr. Lewis, like Dr. Gavin, myself, and other docs, you can have all the skill sets in the world, but if you have poor bedside manner, it really blunts the whole doggone thing. So here was a question that was posed, and I'm glad that you're here to answer this question. It says here, what is the cause of the feeling of phlegm in your throat, and how can you get rid of it? You muted? There you go.
Okay. That's a good question. The short answer is, if I had that answer, I'd be sitting on a golf course right now. But the long answer is it's a combination of things. Typically, it's as a result of perhaps an underlying allergy, right? So the oral or the pharyngeal or your throat mucosal lining is really responding to something, right? Something is triggering this increase in production of phlegm and mucus. So what we do is we have to find out what the causes are and not just treat the symptoms. And so that's why most of these patients have to come in and undergo really a formal evaluation to figure out what are the triggers, what's causing this. Is it, they sleeping under the AC? Is it environmental allergies? Is it a food allergy? And then once we get down to the root cause, and we can hopefully help mitigate some of these symptoms.
Awesome. And this is really nice, Dr. Gavin, because we have the pretty much the oral surgeon on with the oral hygienist, dental hygienist. So you guys must work together somewhat. I'm sure that you have an oral hygienist. Do you, Dr. Dubney? I'm sure you must.
Well, and when you think of us as otolaryngologists, we are the soft tissue surgeons, and then the dentists and the oral, they're basically let's think of them as the orthopedic surgeons of the oral cavity, right? They do more of the bone work.
But isn't that some of the bone work or the teeth, when they become bad, it certainly affects the soft tissue?
Correct. I mean, as previously stated, right, there's really that link between that oral inflammation and systemic disease. That's really important. Where I come in is at the other end in terms of oral cancer surveillance. Right, this increased risk of oral cancer in African Americans and its association with HPV. Now we're seeing a more aggressive form of oral cancer in Black women that don't have the traditional risk factors, such as alcohol and tobacco. So,
when Dr. Duvernay mentioned HPV, that's a serious thing, especially for young girls coming up. And HPV is human papilloma virus, and they have different stereotypes of that. I think it's the 25 that causes most of the problems from an oral standpoint, I believe, relating to oral cancer in men. I know that they did extensive studies, evidence-based studies show that there is a definite higher risk factor for those men that have oral sex on females that are HPV. We had a famous actor, he's still alive, Michael Douglas. Remember him? Yeah. He had an HPV, and that's how he got that. So I'll let it go. I know Melissa.
Yeah, I think Melissa had a comment that she wanted to make to Dr. Demonier's.
Yeah, I was just going to mention, two things. In the oral cavity, when I'm doing my examinations on my patients, I do see signs of patients with reflux disease, and they don't even, a lot of them don't even, they're not symptomatic, they don't notice that they even have it. But I can see the symptoms, and I do go over that with them because, the increased risk for cancer because of the reflux with their, or pharyngeal, the throat. So that's one thing that I do with my patients. And I do refer them to the ENT to have that examined. And on the other note, I've caught 5. I haven't diagnosed, but I've found lesions in the oral cavity over my 25 years 5 times, and all of them have been related to HPV.
Okay.
So in terms of prevention, that's why, it's really important because, what you guys are doing, it really educating our, our folks that the need for vaccination, right? This is a preventable disease. And I think if we can really educate our population in terms of getting these vaccinations, I know now is a push for a lot of anti-vax, but the data is out there, and that's where we as professionals, we really have to educate them and tell them that these vaccines are safe and they can help prevent and or eradicate, something as simple as oral cancer and cervical cancer.
Okay. Do you have any questions that you've been getting, Dr. Gavin? I have another question here is, what is the early signs of a stroke? Being an ER doc, I feel very, very good in answering that particular question. And Dr. Lewis definitely chime in, being a cardiovascular disease person. But typically, the early signs of a stroke that we see, it can range from a whole compadre of things, but typically, there's oftentimes slurring or there's straight, I wish I could run back, the sketch that I did, because I think that was classic, but I won't do it to y'all today. But my speech became slurred. I began to lose control through weakness on one side of my extremity. And the stroke is on the opposite side of the weakness. Follow me? In other words, if you have right-sided weakness, you've had a left-sided stroke. That's how that works out. I mean, it crosses over at the port level. That's how that happens. So you have like blurry vision. You can have double vision. You can have nausea, vomiting, slurred speech, of course. Aphasia, where you just can't, you know the word, but you can't get that word out. And it's frustrating. And people show the frustration of that. Anytime you have any dizziness, you can sometimes pass out. And it depends on the type of stroke that you're having. If you're having what is called ischemic stroke, which is about 85% of all strokes are ischemic stroke, those strokes, we want to catch them early, really early. We say that the time for us to catch those strokes after the onset of symptoms. Can someone mute your mic, please? I'm hearing somebody's mic. When we look at the early onset of symptoms, that means not when you wake up the next day and get to the emergency department. No. Your time starts counting. The clock starts counting from the moment you have symptoms. Let's say you fall, whatever it is, and you're having a stroke coming on. You have a stroke in progress. You want to get to the hospital ASAP, certainly within a matter of an hour or two. We have up to 3.5 hours to give you what is called TPA, which is a blasting agent that opens up the artery if it's clogged, right? That is ischemic stroke. You can break off a clot that maybe comes from your neck. The internal carotid arteries go into your brain. That causes a problem too, obviously. You can have something like atrial fib. Throw off a clot, the heart is beating irregular, goes off a clot, upside of your neck, into the internal carotids, and you have a stroke also. That's also a clot. But those clots can be dissolved unless you have some other issues going on. We have to hold off on giving you the TPA because of your sugar may be too high, blood pressure may be too high. If you're on any anticoagulants, it's a problem too. So we tend to hold off on that. So we do ask questions. The first thing that happens when you come to the emergency department, we check for one quick thing. We do a quick within a matter of a minute. We know basically what's going on. The only question that we don't know is it ischemic or is it a bleed? Bleeds are catastrophic. A bleeding stroke, hemorrhagic stroke, will take you out in no time or will leave you pretty much in a really bad state in terms of recovery. most people do not recover from those. There's a high mortality and or death rate associated with hemorrhagic strokes. So a hemorrhagic stroke is where a blood vessel bursts. When that happens, we always say, you want to pray over everything, obviously, right? But when you have a hemorrhagic stroke and it blows, then that's a real problem. So when you have hemorrhagic stroke, typically you have a massive headache, typically, because the brain is inside of a skull, it's inside of a shell, does not expand. So what happens, because of the bleeding, it pushes the brain further down into what we call the uncus. That's your brainstem. When you herniate through the brainstem, you're dead, right? So you want to make sure that you listen to your body. If your body is telling you things that you get dizzy, let's say you turn your head real quick, you get dizzy just in doing that. You may have a plaque. I'll let Dr. Lewis talk on that, but you may have a plaque clot inside of your carotid artery that may need to be taken care of. So, Dr. Lewis, you want to add anything to that?
You need to unmute, Tony. Tony, you need to unmute.
Sometimes I have a tendency to mesmerize people, and they just lose it. But
there you go. I was trying to get it unmuted. Sorry about that.
Yeah.
Plaque in the neck obviously is one of the leading causes of stroke, and as Dr. Reynolds mentioned,
I can just barely hear you. Tony, you have to speak up a little bit. I can just barely hear you.
Dr. Reynolds mentioned the atrial fib, the irregular heart rhythms, can be a real serious cause for blood clots and ischemic stroke. Patients who have what we call the left atrial appendage in the left atrium, they tend to have clots formed in that left atrial appendage, and that's where the Watchman procedure is now very beneficial, where you can no longer develop clots in the left atrium. So yes, atherosclerotic plaque in the carotid arteries can lead to ischemic stroke, and so those are the main two factors that we look for: the left atrial appendage and atherosclerosis involving the carotid arteries.
All right. Is there another question that we have here?
Let me just cover a couple that have shown up in the chat. And one of them is, how do you lower high blood? Somebody needs to mute their mic. How do you lower your high blood sugar levels quickly? So my presumption here is that you're talking about a person that has a reason for having high blood sugar in the first place, having diabetes. High blood sugar levels can be brought down quickly. The most expeditious way of doing that, of course, is with insulin. Okay, that is why that is the first treatment when you have something like hyperosmolar coma, when you have something like DKA, or when you have blood sugars that are extraordinarily high. It's insulin. But then you can bring blood sugars that are moderately high, you can bring them down by a variety of other things. You can, by withholding food, okay, and increasing physical activity. But generally, it's going to require some kind of pharmacology, and that's, for the most part, insulin. There's a question here. Do you need an endocrine team to monitor your thyroid condition, or is it sufficient enough for your doctor to monitor your thyroid with your blood work? That's a very, very important question. Remember, there are various kinds of thyroid condition, okay? If you're simply trying to follow whether your thyroid function is high or low, that is hypothyroid for low, hyperthyroid for high, you may not need an endocrinologist to monitor that. That is something that your primary care provider can do by monitoring your levels of T3, T4, or TSH. That is the hormone that's produced by your pituitary gland that affects your thyroid gland in the first place. Endocrinologists become important when the severity of the condition becomes more complicated. Okay. If you have, for example, something that is ambiguous, you might have one of those odd thyroid conditions like a thyroid cancer. You may have something that involves not just the thyroid gland, but within the thyroid gland are some other glands called the parathyroid glands. They can be abnormal. Then you need the help of somebody like an endocrinologist. But for routine monitoring of high levels or low levels of thyroid function, your primary care provider generally can cover that. Yeah, Dr. Reynolds, I'm wondering if you find it would be helpful for you to cover the questions that were submitted
Sure.
prior to this session.
Sure. And I also have Katrina. She's a medical student. Her hand's been up for a while. So Katrina, you want to ask your question?
Hi. Hello. Hi. Yes, I had a question. I wanted to know about like PCOS since the metabolic, hormonal aspect, reproductive aspect is all interconnected. How individualized should treatment be for each patient based on symptoms and different body types? That question was for Dr. Gavin.
Yeah, thank you for that question. And we did have an opportunity. I don't know whether, Katrina, you had a chance to hear our women's health session, but we talked about PCOS at some length then because it really is an important condition. Because as you know, one of the problems with PCOS as a woman's health issue is that your androgen levels are too high. That is, the male hormone type hormones are too high, and that, of course, counteracts the female hormone action, so that you get, for example, interruption of menstrual cycles. You get an inability to ovulate, okay? And you also develop other problems like insulin resistance and inflammation. And that's why PCOS is not only an endocrine disease, that is because it disturbs hormonal cycles and it disturbs reproductive functions. It also sets a woman up for metabolic problems like diabetes. Okay. And so what becomes important under those circumstances is, of course, to try to restore the androgen estrogen balance and to try to reduce that insulin resistance. That's why you really need the benefit of medications in many instances. And you also need to attack issues like underlying obesity, underlying insulin resistance. And if there's already some abnormal glucose metabolism going on, that needs to be addressed in a very urgent way.
I have another question here to Dr. Gavin. This is pointed to you, Dr. Gavin. And I love this question. It says, I'm asking for a neighbor. I love that, right? Asking for a neighbor whose elderly family member has been on dialysis for 8 years. Labs came back good, and they discontinued dialysis. Is this evidence-based practice?
Okay, there are a couple of things here that we really want to be sensitive to, okay? I'm always suspicious when somebody tells me something like labs came back good. Okay, remember, don't talk to me about conditions that can be monitored by metrics in terms that are descriptive. I don't want to know that your blood sugar is good. I want to know whether your blood sugar is 100 or 250, okay? I don't want to know if your blood pressure is okay. I want to know whether your blood pressure is 120 or 195. Okay, so we need clarity about what you mean by the labs are good. So just as long as you're clear on that. If you're saying that your labs are now at a level where you're not at stage 5 chronic kidney disease, which is dialysis requiring kidney disease, if you're now talking about an EGFR, your filtration rate of the kidneys has now been restored. And remember, you can sometimes reverse these situations. And many of these newer medicines are very, very helpful at reversing certain stages of kidney disease. It's unusual for a person to be on dialysis for chronic kidney disease. For acute kidney disease and acute injury, you might see some reversibility. But for chronic dialysis, to see a person reverse that condition to the point where they no longer require dialysis would be unusual. Impossible? I can't say it would be impossible, because you need to know more about what the underlying condition was all about. But yes, if the laboratory values indicate that the kidney function is now back into an acceptable range that does not require the benefit of dialysis, certainly it is appropriate to take that person off of dialysis and simply monitor them going forward. But it would be a very unusual situation for a person who's been on dialysis for that length of time.
I have a question here, and I'm going to put this to Dr. Lewis. What supplements, if any, should be avoided if you're taking blood pressure medications?
Supplements to be avoided.
Mm-hmm. In general, I guess.
Well, I guess in general, there's so many supplements that it's difficult to really concentrate. Anything that has added sodium or heavy amounts of sodium should be avoided, because obviously blood pressure is influenced by the sodium content of your daily intake of sodium. Things such as nasal sprays, these other types of that have the vasoconstrictive qualities in them should also be avoided. In general, I guess that's my answer, because if I could speak more specifically, because I'm not sure what supplements they are. Supplements can be anything, and they can include a wide variety of substances in the supplement. So without knowing exactly what you're taking, it's difficult to sort of concentrate on what not to take.
Okay, I have a question here for Justin. And the question was, does exercise bands...
Dr. Reynolds?
Yeah.
Could I just to add on to what Dr. Lewis just said?
Go ahead.
There are some instances where people who are taking those supplements that we don't normally find ourselves prescribing, but people who take things like ginseng, and who take things like licorice root, and extra things that contain extra caffeine. Any of those kinds of supplements that can increase your sympathetic activity, your sympathetic tone, those run the risk of increasing blood pressure. But Dr. Lewis is hit the nail on the head. You really need to know from that wide universe of, quote, supplements that people can be out there taking, what is it that they're really ingesting that would put them at some risk?
Okay, Dr. Gavin, could you threw out a word there, of course I know, but you may want to explain very briefly what is sympathetic tone.
Okay, sympathetic tone is it you have something called a reflex called fight or flight, and that's something that it means that your nervous system is now activated. Okay, and that's done by internal hormones called catecholamines. Okay, you've heard of adrenaline. When your adrenaline levels are up, that's increased sympathetic tone. The sympathetic nervous system is what determines your level of readiness, alertness, fight or flight. That's what we mean by that.
Okay, I have a person have their hands up. It's Teresa Jones. Ms. Jones, go ahead.
Yes. Hello, everyone. I want to ask just one question about when my dad was in the hospital. They say his levels was too high in his kidney, and they gave him when I tried
what levels, baby? What levels were too high?
His kidney level, and
okay.
They gave him They gave him the stuff that you give for cancer. I can't think of it. It's the stuff that they give when you have chemo. They gave him chemo, and I asked the lady, I say, he doesn't have cancer. She said, oh, well, they can use that. That can help get the kidney levels down too. And then another nurse, she said all they had to do was give him a lot of liquid, because the chemo paralyzed him from his neck down. And then he wind up on dialysis, which eventually it all took his life. Um, so that's a question that's been puzzling me since my dad passed 3 years ago. Is chemo posted, is that used for kidney levels?
One, I think you have to know, I'm sure Dr. Gavin speaks to that too, but I would want to know, just being just regular doc, right? The little country doc. I want to know basically what chemo was he taking. I want to know more about his kidney in terms of his kidney functions. Are we talking about his GFR? Are we talking about his creatinine? Are we talking about his BUN? Are we talking about him having high potassium levels? I need to know those things before I would be able to entertain it. But Dr. Gavin, you can go ahead and give it a shot.
No, I think that's right. I think you need to know a great deal more about exactly what the underlying condition was, what levels were high, that related to his kidney function. And then if he was given drugs that went under the label of chemo, what drugs what were those drugs, and what levels were administered to him, and for what reason? So there's unfortunately a lot more detail that we need to have before addressing the different parts of your question. One that has to do with the kidney itself, and the other has to do with what was this, quote, chemo that he received, and for what purpose was that given. That's something that we may be able to take offline and maybe with a little bit more information.
Now, thanks for the question, Teresa. I had a question here for Justin that came up in one of the pre-questions here is stretch bands. They want to know, Justin, how effective are stretch bands for people that live a sedentary life that's 64 and over. Otherwise, then they said decent. I'm not sure what decent health means, but I would imagine that means they're able to, to move around. So they want to know about stretch bands, as opposed, I guess, to maybe some other way of exercising without there being any high impact. Can you comment on that, Justin?
Yeah, there we go. Sorry, I was trying to go ahead and do all this stuff at the same time. Can you hear me?
Yeah.
Wonderful. Stretch bands.
I cannot see you, but I hear you.
I don't know why. Hold on. Don't know why you can't see me still. Still can't see me? Because that's my thing.
Can you guys see Justin? Because I can't see him.
Yes, we can see him.
We can see him perfectly fine.
Go
ahead, Justin, talk. Your daddy has seen you enough. Go ahead.
Are you suggesting that cataract's problem? Doggone it. Go ahead. Yeah, Justin, go ahead.
So, anyways, no. Bands is definitely a good thing, especially for people who, whether it doesn't matter if you're old, young, that's not really the basis of it. I think depending on what you're going for, even people like myself, I still use bands to this day. Bands for me personally, just for the tension and keeping the blood flow where I want it to be kept. Some people think that you can't get the same pump or the same amount of blood flow to your to your muscles if you were to just do dumbbells and kettlebells and stuff like that rather than just doing bands. Bands can vary from 10 pounds all the way up to almost 100 pounds. They're not going to be heavier in the sense or like, oh my God, this is like 100 pounds I'm holding. No, it's just the stretching part of it is really the 100 pounds, just resistance. So I think what they really meant was resistance bands and not really stretch bands, which same thing in a sense. But yeah, if you can go towards more of like the beginners, like 10 pounds, so like I would say 10 to 40 pounds of like resistance would pretty much do you justice for whatever you're trying to do, whether it's arms, whether if it's squatting and stuff like that. It definitely can help a whole lot more, especially for people who aren't that, I guess I should say, comfortable being at a gym. Some people are like, what can I do if I go to the gym? Or I'm sorry, if I can't go to a gym, if I'm at home or if I'm on vacation, so on and so forth. These things are bands. You can put them in your bag, travel with them. You work them out at at your hotel room or at your house or whatever. So those things, convenient wise, is definitely something that I would definitely use.
A person that's my age, 70 plus, and I'm getting in better shape for sure. Weight is down, playing more golf, but I want to end up becoming like the Incredible Hulk. I want to bulk up. Is that something I should be trying to, even though I'm in good health for the most part? Okay, is that something that you would recommend for someone that's 70 plus years old, in terms of doing some heavy weights and those kind of things?
I would say there'll be a lot more than just doing bands for someone who's in their 70s. I would say a diet. I would say a program. But yes, if you can go onto some bands, it'll be very beneficial for you, especially if you're not used to working out all the time. But again, I don't want to discourage people from going into weights either. There is nothing wrong with starting slow. You can start with 5 pounds or 2.5s or 7 pound weights, stuff like that to just get you going. It doesn't have to be just, straight on resistance bands. But if we are just talking resistance bands, there's nothing wrong with that. Yes, I would definitely go with like a 20-pound resistance band and, do some curls, some military presses, which is shoulder presses, stuff like that. You could still get full range of motion, especially for someone like yourself who has shoulder issues. Full range of motion is going to be a problem. So I know you said something about playing golf, range of motion, right? So those things are a pretty big deal if you want to get better range of motion. Then things like bands will probably be more beneficial to you.
I have a comment for what you just said. You're talking about my golf game now. That's it. That's just personal. I use stem wave, damn it. And we went out. We were on the golf course last week. I think I was putting somebody's butt. I'll just leave it at that. There's a hands raised up by Miss Briggs.
Good morning.
Good morning.
Mine is kind of off that subject. I've been like going crazy. My husband was diagnosed with leukemia about 18 years ago, and on the 27th of April, he could not go to the restroom. So I took him to the emergency room, and they ran the CT scan, and then the doctor didn't even come back in. He says, go home and take Metamucil. Brought him back home, still nothing. He was in such excruciating pain that Tuesday I took him back. They ran, they took the CT scan the first time we went. And then on May 7th, we went back to the emergency room. They did another CT scan. He was in excruciating pain. So one of the doctors said, no, I'm going to admit him. And why didn't someone look at this CT scan and see that there were issues? I told him, I'm not the doctor. I'm a nobody, right? So they took him in. They did the liver biopsy because he has lesions on his liver. Mm-hmm. He has lymph nodes in his abdomen area. He has the cancer in his spine. He has all kinds of things going on, and nothing helps him. No pain medicine, and I'm just besides myself because he's constantly in pain. We did the biopsy on May 8th. As of today, they say they have not gotten it back. Now, the doctor, when we went in, they said that they had preliminary reports that he has now gotten T-cell lymphoma and also B-cell lymphoma. So I don't know what to do. We have an appointment on Monday because they said that they don't know what chemo to start him on until they get that report because they don't know where the cancer started and where to trigger, what area to trigger.
Got it. Let me make a comment, I guess, real quick on this one, and I'll let Dr. Gavin deal with the blood cancer part of it. If we went to the emergency department, I always tell ER docs, I do some teaching and training, and at least I used to. you put a finger in every orifice. Finger in every orifice. Did they ever do a rectal examination on him?
No.
That's what I figured. Okay, and because you mentioned Metamucil, that's a couple of CT scans, but I bet no one ever put a finger in his butt, and
Nope.
that is absolutely ridiculous. I was always told the reason to have a finger put in if you have a hole, that means your mouth, other areas, and certainly your rectum, because oftentimes patients will suffer from what we call fecal impaction, and that will be a very painful thing as well, especially on top of chemo and other medications that they're probably on. The other thing that I mentioned that
Well,
I'll stop on.
he's never taken chemo yet.
It started yet, yeah. The other thing for is pain. Pain is one of the things that we try to keep people away from. One of the tenets of our Hippocratic oath that doctors take is to, above all, relieve pain and suffering. We work to do that, right?
Mm-hmm.
I'm not a big advocate of medical cannabis, but he should talk with his doctors about doing it. I've had a couple of my very, very close friends that were in a terminal stage of their prostate cancers, started them on medical cannabis. They woke up, they were happy people, they were eating people, they were able to sleep and no pain. Okay, so and that's one of the things that we call a covered event, a covered condition to be on medical cannabis. So that's something that he really should look into. And it seems to do a very nice job. But more importantly, he will stay in connection with his surroundings, with his loved ones. Okay, so that's for that. Now, Dr. Gavin, you may want to make a comment, I guess, about the lymphomas A and B, the Burkitt's lymphoma, or what have you.
Yeah, it's not very clear what is your situation, the underlying situation, Ms. Briggs. You said that your husband was diagnosed with leukemia 18 years ago?
Yeah, he was a firefighter, and this is something that they have been noticing in a lot of the firefighters. They're coming up with leukemia and prostate cancer. So he started off with prostate cancer, and then he had it removed. And then this is when they found out that he had leukemia.
Okay.
And then they said that the T cell of the large granola, something, granular something. And then since this last bout, he has never been diagnosed with B. Now he has B.
Okay. So this is part of why it's kind of confusing, because your husband has a history of multiple cancers, and he has had a history, you say, of T cell leukemia, and then there may be B cell leukemia, and then you also mentioned that there's lymphoma. Lymphoma is a solid organ tumor, not a blood cell tumor. So there is a complexity of his history here, which means that your husband may be one of those people who suffers from multiple cancers. So I'm a little surprised when I hear you say he has not had chemo at all.
No.
Through all of these?
They said that the issue is so complex.
Yeah.
They took it on May. They did the liver biopsy on May 8th, and they still have not gotten the final pathology report.
Okay. So I have two general comments to make. One is that, make sure that whenever you have these kinds of discussions, and I always say, hold your providers accountable. If you don't understand what it is they're saying, make them write it down, or you write it down, okay? So that you will know exactly what is the diagnosis that they're working on. I mean, what is it that you think my husband has, okay? And if it is a acute lymphocytic leukemia, you write that down, so that way you can talk with clarity about what your husband's condition is or was at a given time. If you think my husband has B cell lymphoma, then write that down. Okay, write the date down so that
it's on the preliminary pathology report.
Okay, but now if there is a diagnosis that somebody has has given you. Okay, now the question becomes, what is the treatment for this? Okay, and if a diagnosis is there, then your next question is, well, what's the treatment? And if somebody tells you no treatment, you know what? You need to that's time for a second, if not a third opinion. Okay, because something is not right when you tell me that 3 weeks ago your husband had a biopsy that has been sent to a pathologist somewhere, and the diagnosis is not back yet. No, something's you need to look further here because
and I'm having great issues of getting him to eat. It's like he's dropping like 2 pounds a day.
Well, this is what
And
happens
I've been giving him Boost because they said that the lesions in his liver and the lymph nodes in his abdomen areas are what's causing the pain. So he's not able to eat.
Miss Briggs, and I'm cutting you off. And then Dr. Gavin, we want to keep it moving, but this is what I like to do. I'm a patient advocate. I love hearing this. I don't love hearing this stuff, but I love getting involved in it. Who's your pastor?
Your pastor.
Who's my pastor?
I see you.
Okay. Well, we have to have a conversation then.
Yeah, so, I'll stop you tomorrow if you come. Yeah, I'll see you.
Yeah, I'll see you at church tomorrow. Yeah, do that. But listen, there's something that really came up nice in the chat from Sharice DeBose. 11:36 a.m. came up. She says, I'm proud to share I am part of a clinical trial of multiple myeloma at Emory Winship Cancer Institute in Atlanta. I'm sure that Dr. Gavin knows that place well, probably.
It's absolutely.
Yeah, it says, I had the stem cell transplant on 10/17/24. I am considered in remission based on the clinical trials monthly treatments. This, guys, is a reason why we need to get involved. We'll be talking to the pastors, Pastor Philpott. We need to get our pastors involved as trusted advisors, trusted people within the community, as well as doctors, to get our people more involved in clinical trials. That puts you at the cutting edge, amen, at the cutting edge of the new things that are coming up. You become pioneers. This is not like taking guinea pigs. Dr. Gavin, he knows the clinical trials in and out because that's what he does also. And he sits on the advisory board. So he knows how this stuff works out. As long as we know that this is really something that could potentially benefit us. Now, clinical trial does not mean that you're going to get the actual medication. You may end up getting the placebo. A placebo is where it's like giving you glucose, dextrose and water maybe, right? But the clinical trial itself is something that is meant to develop new things. And if we're going to be at the cutting edge of new things, we have to be willing to participate in those human clinical trials in our communities of color. Thank you. So that was very nice. I had to get that one out because to me it was pretty awesome that the person was even thinking about that. There's some other things we went over that. Thank you for the awesome information. Stroke question. Here's a question about. It's a stroke question. Oh, that's from Pastor Philpott. What questions should be asking my physician during regular visits if there is a history of strokes in my family line? The physician should be asking everything that I said that are things that are signs of stroke. They should be asking those kind of questions. Dizziness. Do you feel lightheaded? Do you have a balance issue? Are you falling? Are you having more headaches? Are you seeing double vision, visual disturbance of any kind? And then the doctor should listen to your neck. If the doctor's not listening, it's like not putting the finger up someone's butt to check out their rectum. If you're having questionable stroke issues, you want to check out the carotid arteries, right? And the carotid artery has it sounds just like heartbeat, boom, boom, boom. But if it's boom, 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 that means that there's turbulence to flow. When there's turbulence to flow, that means that there is a plaque that is blocking the flow and it's no longer going smoothly. So those patients should always ask Pastor Philpott, why did this in my neck? I think it may be having stroke symptoms. That's one of the first things that you do, other than, of course, listen to the patient's heart, because you want to check out that atrial fib also. But listen to the neck, you're going to get more from that than listen to the heart, to be honest about it.
Can I add to that,
Yeah, please.
Pastor Philpott, that you also, a person that has a family history of a condition like strokes also needs to know if they have other risk factors for stroke. They need to know what their blood pressure history is, what their current blood pressure is. They need to know what their blood sugar is and what their potential diabetes history. Those are the kinds of things. They need to know what their cholesterol level is and what their lipids look like. So all of those things that we put in the bucket of risk factors for things like strokes also need to be monitored carefully on a regular basis.
This one is for Dr. Morrison. This is a patient that is online over there in Orlando. I guess at most likely our health fair event over there. And the question is this, Dr. Morrison, she asked, how many calories should I be eating each day? Now, she's not a diabetic, apparently. She wants to lose weight. She's at her age. Now, she did not state her age, but I'm not sure what that means. But I'm looking at folks more on how many calories should be eating each day. Should I be eating each day?
Thank you again for the opportunity to answer this question. Normally, if she's of good weight and she's exercising, we do the Harris Benedict formula, which is 25 kilocalories per kilogram of body weight that give her calories. If she wanted to lose a little bit more, she can lower it less than 25, maybe go to 20 kilocalories per kilogram of body weight, and that'll give her calories. If she's obese or overweight, we normally use a Mifflin calculation to calculate calories, and or you can go to 15 to 18 kilocalories per kilogram of body weight to get the calorie needs.
Okay, thank you. One last question for me, just going through the chats. It says here, okay, I was never told anything about PCOS and I'm diabetic. I have facial hair, but what should I ask my diabetic doctor?
Dr. Reynolds, I have sent Ms. Baker an answer in the chat.
Okay, gotcha. Yeah, that's Ms. Baker, right? All right.
And I also wanted to add with the PCOS to avoid foods that can cause inflammation. So, fried foods, sugary beverages, processed foods, those type of things we don't want. And then, of course, saturated fat, alcohol, refined grains to avoid those. And, of course, increase complex carbs, foods high in antioxidants, whole grains, colorful vegetables, colorful fruits, fresh preferably. Thank you.
Miss Jones, but looks like she's frozen. Okay, there she is.
It's just a quick question. Many strokes in the brain. Can you detect that? Can the person detect that, or is just something that just you can't detect? The person.
Yeah, I can answer that one too. Mini stroke is what we call it. They call it TIA, a transient ischemic attack. And I tell people this: if you have a TIA, that's a precursor to what's coming down. Could potentially be coming down the road for you. That means that you need to be checked out. And you have very similar symptoms, by the way, as if though you had a stroke. It's just that it's something that usually lasts less than an hour. Sometimes they can go beyond that, but usually it's less than an hour. So you may have slurring of your speech. You may have a facial twist. You may have weakness in your extremities. It's a scary thing. But usually by the time they get to the hospital, it's already gone through already. In other words, now you need to have a thorough evaluation that does include an ultrasound of your carotid arteries. It includes an ECG, obviously, to make sure you don't have atrial fib. So I hope I answer your question there. But typically, you want to adhere to what your body is telling you. Listen to what your body is saying. If you have symptoms that you know that you don't normally have, you're having some issues going on that you don't normally have, the body is giving you signals, right? So it's signaling you to certainly to have things evaluated. When you go see a doctor, you want to make sure that you're being evaluated. Dr. Gavin, anything you want to say before we close?
No, just thank everybody for the time that you've taken today. And I hope that we've touched on some issues that you've been concerned about. And going forward, please make sure that we are aware of concerns that you have. And remember, always capture as much information as you can when you talk to your healthcare providers. Write stuff down so that you can read from lists. So that's the only way we can have complete information when we get ready to, answer and address questions.